This episode of NeuroNights comes to you with support from the Ohio State University Wexner Medical Center, which has dedicated brain injury specialists at each level of care. Our inpatient and outpatient services are CARF accredited and a part of the Brain Injury Model Systems. For more information on our brain injury program, please scan the QR code or go to go.osu.edu/brain injury.
Good evening, everyone. I'm Sheital Bavishi. I'm a physiatrist, as Kedar introduced me. I am a physician that works at Dodd Rehab Hospital, and I also work at Martha Morehouse for outpatient clinics. My primary focus and specialty is brain injury medicine, but I also specialize in spasticity medicine as well. So majority of my patients are all some kind of brain injury, whether traumatic, acquired, anoxic, and I follow them both at Dodd and then long-term as an outpatient as well. So I'm the medical director of the brain injury rehab program at Dodd and also for our outpatient settings for rehab. And Alicia is one of our doctorates of PT. She works over at Martha Morehouse. She's our brain injury team lead. She's also part of our outpatient neurological rehab team, as well as Neuro Recovery Network and adaptive sports team. So anything else to add to that, Alicia?
No, that was perfect. Thank you.
Okay. So we will try to get, okay. So the main thing that I wanted to bring up is we always have a lot of questions, and I get a lot of questions. Is there something new going on in brain injury? Is there research that's happening? What is research? And do I get involved in it? What can I do in research? A lot of patients want to really help other people with what's happened to them and be able to share their story as well. So part of research is using knowledge that we already have and using patient populations that we already have, and then trying to figure out how do people recover. What different things do we do for different patients? Is there a way that we can have a new concept, a new method, some new understandings about brain injury, about recovery process, about the early parts of brain injury, and how do we help people not have such severe injuries or such prolonged recoveries? And some of it is talking about chronic brain injury and, what can we do for our patients that are already brain injured, that are trying to get back into society, trying to get back into living their lives, and are there treatments or therapies or things that could potentially help them? So a lot of research is really trying to find new knowledge, but also use some of our existing knowledge and then find creative ways to kind of create new guidelines for treatment, new guidelines for care, both in the acute setting where in the emergency room and the ICUs, but then also in the rehab setting, and then as we get further down the road for kind of lifelong. So why do we want people to be a part of rehab or research? Well, we want to learn about what happens to you. We want to know how we can create standards of care that could potentially help more people. So part of the reason we want people to be in research is really to get to understand your experience, understand your story. How can we use that to help someone else and help people in the future? We also want to be able to have a lot of our patients have access to experimental treatment. So, right now in the changing world of healthcare and, insurance companies and Medicare and whatever there is out there, there's a lot of new treatments that are trying to be brought out, but the insurance company is calling them experimental, or they're not quite, they don't have enough data yet, or they don't have enough standardization yet for insurance companies to pay for them. But some of them are really expensive, and we'll talk about a couple of them today. And so people can't get access to them. So sometimes when they participate in research, they have access to experimental treatments that they may not have otherwise because they're not covered by insurance. But it also helps for the patients to gain a better understanding of what happened to them. People will always talk about I got hurt. My primary doctor didn't know what to do. In the emergency room, like I went to the emergency room, they checked me out, they said my CAT scan was negative. When you have a concussion, and they send me home saying things will get better. But I don't really know what happened. I really don't know why I'm still having these problems. And so research can also help patients gain a better understanding of what's going on with them, going on with their brain, going on with their recovery, what some of the different therapies that they're going through or the medications they're going through. So really research is kind of a catch-all, and it's kind of it's a nice, well-rounded way of not only for you to be able to, or patients to be able to give back, but also for patients to be able to understand and learn. So in Ohio, I pulled up some of the stats. These are the most recent stats we have are from 2017. Now there's a lot of words on this page. I'm not going to read them all to you and put you all to sleep, but the basics that I want you guys to have from this is really to know how prevalent brain injury is. And this is just in Ohio. And since we live in Ohio, I wanted to kind of bring out the statistics that were brought out by the trauma registry folks. And that were, you can easily Google this and find brain trauma registry stats for Ohio, and you can find all of this information. But, the big thing is TBI, more than 2,600 Ohioans died from TBI, and more than 120,000 injuries were treated in emergency rooms, and that was in 2017. So when we talk about, we're living in a pandemic, people are at home, people are, not getting out and doing a lot of things, but they are doing other things, other kinds of activities, like ATVs or going for rides on their motorcycles. So we may notice that some of these numbers are increasing. We may actually notice that some of them are decreasing because people have stay-at-home orders. We don't have that data yet. But what we do know is that for every 100,000 Ohio residents, 21 of them died because of a brain injury. And so that's quite a large number when we kind of go through over 10 years. That's the death rate has increased up to by 17%. So that's pretty large kind of statistics and numbers to think about. People will throw out numbers. There are 1.7 million new TBIs across the country a year, and there's almost 4 million people living with a chronic brain injury across the country. But if you kind of go down through it, and when they look at persons that are hospitalized or people that have at least one TBI in their lifetime, it's estimated almost 2 million, 1.9 million Ohioans have had at least one TBI in their lifetime. And nearly 250,000 of those have had moderate to severe TBI. So brain injury is very prevalent. It's sometimes the unseen injury. Some people will have brain injuries and you can't tell if they've had a brain injury. They're not in a wheelchair, or they're not having trouble with their gait, or they're not having trouble with their speech. Majority of people that have TBIs have concussions, and so you don't see any outward appearances of that. But there's definitely an inward or an inside injury that's occurred. So that's the main reason we need research. That's the main reason we need to understand what's happening. There are so many people that are affected by TBI, not only the person that had the injury, but their families as well. And then also clinicians. Clinicians need to learn and understand about brain injury, how to help treat people, how to help rehab them. So this is where research really comes into play. When we have such a vast population of people getting brain injuries, we need to understand how we can treat them and how to help them continue with their quality of life and continue to get back into society. So these are statistics from 2017, but when we go down to my very last point on this, more than 550,000 Ohio adults have both a disability and a history of TBI with loss of consciousness. And, 135,000 Ohio adults have both a disability and history of moderate to severe TBI. That's quite a number of people. That's almost 500,000 people, or over 500,000 people that are living with some sort of a TBI and a disability. So it is something that we as clinicians, with physicians, therapists, nurses, everybody need to learn and understand a lot more about, because it affects quite a few people that we will be in contact with in our lifetime. So, the other stats that I throw out here are how many people are going to the emergency room. So, in this graph, the dark blue is TBI, and then the gray is TBI or unspecified injury to the head. So when we look at how, when people go to the emergency room and if they get diagnosed with something, quite a few can be diagnosed very clearly with a TBI, but quite a few, and if you guys can see my pointer, I mean, the gray is a large section. Majority of the people will be diagnosed with some unspecified injury to the head. So even in the emergency room, we can't always diagnose that someone has a true traumatic brain injury or some other kind of injury to their head. And so this also makes us think to ourselves, like, why can't we figure that out? We need more data. We need more research. We need more things that are going to help us understand how we can properly diagnose somebody so we can get them along in the right treatment. So this is all taken from the Ohio Trauma Registry. But this is another big thing. We always talk about majority of accidents happen near the home. Well, this statistics will help us understand that. Where did the place of occurrence happen for people? Majority of people that had a brain injury between 2015 and 2017 were at home. And then the next is they were in the street or on the street. So very few are happening in other types of industries, farms, mines, etc. But home is where a lot of it happens. So some of this research also talks to us about, or this data talks to us about, what do we need to do to help people at home? Majority of our brain injuries for our elderly population are because of falls. So one thing that Ohio State has created is something called a falls clinic, where we assess how people are doing, how many falls they're having, and what kinds of things could be contributing to that. So this data helps us figure out what we can do to help prevent injury as well. So part of the research that we do is just collecting data. So some of the things that we'll talk about today are organizations that are just collecting data on brain injury patients and about what happened to them, where they got hurt, what kind of therapies they had, what kind of medicines they had. So that way we can really kind of gain a better understanding of what we need to do to try to prevent brain injury too. Because, the ultimate goal is we talk about the vaccine right now. The vaccine is trying to eradicate COVID. But we want to try to decrease brain injury. We want to try to get rid of brain injury from happening, and part of that is preventing it. So really learning where it happened, who it's happening to, and it really helps us figure out how we can prevent it from happening. And that's part of research too. So research isn't always this experimental treatment or this experimental drug. It could also just be getting this data so we can put it down on paper, and those of us that manage patients with brain injury or help work on preventative things for brain injury can really figure out what we can do as a group to help prevent this from happening. So one of the things that we have at Ohio State, and it's across the country actually, it's called the TBI Model Systems. There are 16 sites for the model systems across the country. When we include the Veterans Hospital sites, there are 27 sites. So we have 16, we're one of the 16 sites at Ohio State. And what the Traumatic Brain Injury Model Systems is, started back in 1987. And we basically there are 16 hospitals in the country, and we enroll people in the model systems to be able to get data on what happened to them. So we want to look at rehab, we want to look at their emergency visits, we want to look at what happened to them in the acute care hospital, what medical services they got. We want to look at what post-acute care services they got. So after they got out of the hospital, after they got out of rehab, what kinds of things are they doing at home? What kinds of things they're doing in the future? So the real main thing with the model systems is we really want to get a national system where we can create standards of care, where we can really do research on serving people with brain injury. And so, helping out the communities to prevent brain injury. So the TBI Model Systems at Ohio State, we've done quite a few things. developing some clinical practice guidelines. So some of the things that they've developed clinical practice guidelines are for post-traumatic seizures and spasticity, behavioral management, headaches, disorders of consciousness, and then they've identified new therapies, new treatment approaches that we can use for patients with TBI. And then they've done a ton of publications. So nearly 1,000 manuscripts, guidelines, fact sheets. They actually are the ones that there's a Model Systems Knowledge Translation Center. So it's an MSKTC, and they actually have a bunch of fact sheets, patient data, information for families, caregivers, and patients on there to really understand what's happening to their brain. And the Model Systems is an organization where we enroll patients when they come into DOD for inpatient rehab. If they qualify or they meet our inclusion criteria. And we enroll them into this to help get their information so we can put it into this national database and really start coming up with some of these numbers and answers and those type of things. So I believe someone probably put in the chat the MSKTC. Yes, thank you, Alicia. Put in the website for the MSKTC and all the fact sheets that we had access to with the Model Systems. So it's really a great tool, and we're very fortunate to be one of the oldest model systems in the country. We've been part of the Model Systems since the insurrection of it, basically, in 1987. And we have, when I started at Ohio State in 2013, we had enrolled our 1,000th patient. So that was 8 years ago. So be it from then on, we have enrolled even more. And really the goal is to get this national database to really start developing and having these standards of care. And there's already been a lot of standards of care that have been developed. So with the Model Systems, so we are the Ohio Regional TBI Model System. We take part in many multi-site observational studies or other types of studies. So recently we were doing studies on patient-centered care, and that data will be coming up soon, doing things on sleep apnea research in brain injury, and seeing how that impacts people with their recovery from brain injury and getting them the resources and things that they need. A lot of our other parts are doing things like healthcare literacy and understanding brain injury, trying to figure out if we need case manager support services or social work support services to kind of help navigate the system. So at the bottom of this, I did put in the information about the regional traumatic brain injury model systems and some of the contacts as well. Well, other research, there's lots of other research that's going on at OSU. So the first hyperlink that I have there is for the Neurological Institute. And the Neurological Institute also is part of the Ohio Valley Center for Brain Injury Prevention and Rehab. So there's a few different research studies that are going on through there. One of them is something called the Embedded Arts. It's a randomized controlled trial where they're trying to look at creative engagement and motor outcomes. So they're really looking at different things like dance or gaming or other types of movements that we can help with motor recovery and motor outcomes in neurorehab. And so all of these different studies, when we talk about randomized control trials, what does that mean? A randomized control trial is where we have two arms, where we have an arm of folks that are going through the true therapy and an arm of folks that are going through a sham or a placebo therapy. And then trying to see how the two groups do with their overall scores and see which one is better if we did get better results with giving them a specific kind of therapy or a specific kind of drug or whatever the intervention is. So this is contact for the Embedded Arts trial, but even on that hyperlink, there'll be other research studies that you can get contact for. So we have also created a brain bank and Biorepository. And so with that, what we're trying to do is use research and clinical trials using samples that we collect from patients These samples can be of various amounts of things. It could be blood. Some of the things that we're looking at are their blood markers for TBI that we can see might rise early on in concussions to really determine the severity of concussion or how people might recover from that. There are tissue samples and things that we take for looking at different chemicals that are getting altered in the brain, looking at taking CSF or the cerebral spinal fluid. We do have people that also will, people are always asking about donating my brain to science. And part of this is that too, that you can sign up to do that as well, down the road. But they can do biopsy specimens, blood specimens. There's non-invasive and invasive specimens that they'll be taking. But a lot of it with the brain bank and the biorepository is really getting that sample. So our researchers, our biomedical researchers, those that are in the lab, can really look at what's happening in the chemical makeup in the system for patients. And then we can take that from the bench, which is in the lab, to the bedside, taking it to the clinicians or the physicians such as myself to figure out, okay, what medication can I use to do this? Because I see that it's happening, So it's really great. This is a great start for us to have bench to bedside research. So other studies that we have going on, some of the physical activity among survivors of brain injury. So this tells you some of the qualifications that you need to do for that. And what they're looking at is, how physical activity, endurance, they're looking at, how long ago their brain injury was, when did they start and stop receiving therapy services. And so this is another research study that's going on to really look at physical activity. And then there's contact information at the bottom of each of these slides. And so when this is up for the kind of chronic viewing, you guys will have this information as well to look at. So there's a head trauma and vision study as well. So they're looking at concussion and vision issues that can happen as a result of concussions. And so with this study, the goal is to learn about the light sensitivity, to talk about different vision problems that could happen. People always talk about feeling really sensitive to light, having to wear sunglasses, having that, or wearing like blue light blockers or those types of things after they've had their brain injuries. So we really want to study what that is. How is the pupils reacting to that? How is your reading affected? How are different things going on with vision? So, because vision is a big part of what can happen after a brain injury. So there's contact as well for that. It also lists participation. So when you look at research, you also have to look at, am I a candidate for that? So a lot of research studies will have what we call inclusion and exclusion criteria. Inclusion means these are the types of people we want to look at for this, and exclusion means these are patients that don't qualify. And the reason why we want to do that, the reason why we have inclusion and exclusion criteria is because we want to show kind of a standardized thing. So because everybody's brain's different, every patient's different. We try to standardize as much as we can so we can get standard data to be able to create guidelines. So just because you may have an exclusion criteria to something, it's not because something's wrong with you. It means that that's just not the standard that they are controlling for in that study. So there is other studies. There's a concussion registry at OSU that's doing quite a bit of concussion research. And then there's a TBI behavior study. And the TBI behavior study is talking about behavioral changes after people have brain injury. And a lot of these studies are doing, a lot of survey-based, asking questions, surveying caregivers, that type of thing. So those are links for 2 other studies going on at OSU.
Are there any tips for how a consumer can navigate or choose one study over the other to make sure that they're keeping themselves safe or their loved ones safe when they're navigating this tricky minefield, I will say?
Yeah, and that's actually a really good question because research can be very difficult to understand, but also to be able to assess what's going to be something you want to be involved in and what is something that just doesn't make sense. So some of the things that I tell people to look at is that inclusion and exclusion criteria. So if the inclusion criteria is just everyone and they have no exclusion criteria, unless it's a study asking surveys or asking you to fill out questionnaires, you get a little concerned because you want to make sure that whatever thing that they're studying, whether it's hyperbaric or stem cells, they're looking at potential side effect profiles, they're looking at potential interactions, they want to know your medical history. So those are some of the other things to look at. And then the other part of it is, you also look at research in what can you do for yourself? So, for the example, like the hyperbaric oxygen, if you need to do 5 sessions daily and you're trying to work full time, that's going to be difficult for you. That could put more stress on you to do research than it could actually help you. So really looking at what your commitment is to that, is that something that you are able to commit to that won't cause you a lot of stress or won't cause you a lot of other things going on in your life? Because some research does require daily visits or, hour, 2 hours a day, and, some people can do that, but some people have other obligations, family obligations, work obligations, just life obligations. So really you want to be a participant in research because you want to also help yourself, but help others, but also you don't want it to cause a lot of stress on you. And then the other part that I really look at is where is the research being conducted? So, you want to know, is this a reputable place that's being conducted? Is it just random research out there that they're just trying to collect my data? Because we know there's so much fraud going on. So really looking at where it's being conducted, how it's being put together, and then really feel like you have the ability to get all your questions answered. So if you find research studies out there and you send an email or you call and you ask a question, if they're not willing to give you answers or they're not willing to talk to you, or, some things they can't. Some things have to be blinded. Some things they will say, part of our research is we can't tell you whether you're going to get the treatment or not. Part of it is that. But if they're just not really being forthcoming about some of the other things, then you get a little concerned about what is going on with that research. So navigating the minefield of research is difficult, but when you just kind of look at those basics, you can really see, is this something I want to be involved in? Is this something that I can dedicate time to? Because research does take time too. Not only the researcher's time, but the participant's time as well. There's actually a lot going on about gut health and just brain health in general. So it's not just in TBI, but they're talking about gut health and autoimmune and inflammation triggers and just general brain health. And so there's a lot of data and research going on about the types of foods you eat, the nutrition, and how you can decrease inflammation in your body just to keep your brain healthy. They are also talking about that with TBI and how different nutrition and gut health can help with recovery from TBI because you're trying to decrease the overall body's inflammation. So there is a lot of research being done on that. We don't have currently anything going on at Ohio State yet, but there is data coming out on just brain health and performance with gut health. But then when we start talking about it in TBI, there's actually data on looking at fish oil and looking at vitamin D. Those are some big things that we've already got out there in the literature about how those can help decreasing TBI symptoms. And then when we talk about autoimmune, there can be a lot of hormonal changes that happen, especially after a severe brain injury, for like thyroid disorders and different pituitary gland disorders, and how if we can treat those quicker or earlier, we might be able to improve or speed up recovery from brain injuries. So there's a lot going on about reviewing growth hormone as well as one of them. And growth hormone, they're looking at more in the acute phase, like in the ICU and that type of thing. But looking at other things like testosterone and thyroid and some of the other pituitary gland things like our sex hormones are looking in the chronic phase to see how we can help with those. In the slide on TBI Model Systems, there's actually a website on there as well. At the bottom, that website will have a listing of the TBI Model Systems and contacts. And then to join a list for the TBI Model Systems, we can, I will talk to Monica, who is the director of it, and see if they have a listserv for patients. I don't know if they do, because normally they send it out to all the physicians, and then we send it out to our patients. But I will ask her specifically, and if there is a listserv for patients, then I'll give that to Kadar, and he can post it on the CBI. You know, we get a lot of questions. Alicia and I will talk about how many questions we get on some of the newer things coming out, and hyperbaric oxygen therapy is one of them. So with hyperbaric oxygen therapy, you know, people are always asking, like, well, you know, is it good for me? Is it going to help me? Is it something that can help brain injury? I read about this case report, or I read this study on this. And so I wanted to kind of bring it up, because what is hyperbaric oxygen therapy? I get a lot of questions about it. And what does it actually do? So I've listed here, hyperbaric oxygen therapy, it can increase oxygen to the tissues. So it makes sense, right? Hyperbaric oxygen, you're giving high flow oxygen, you're going to increase the amount of oxygen going to tissues. We all know, like, you know, we see those O2 bars and everything like that out there, and we're like, okay, oxygen's good, it'll make me feel better. And it does. It can decrease inflammation. It can decrease cell death. So, you know, initially when people have their brain injury and they have all these cascade of things going on in their brain, from the chemical standpoint, some of those things are attacking brain cells and causing those cells to die off. And that's why we have injury to the brain. It can decrease brain pressure. So, you know, acutely in the hospital or in the ICU, some of the things that the neurocritical care, the ICU doctors are trying to do is decrease the amount of brain pressure that's going on, because the more brain pressure we have, the more likelihood that there's going to be damage. So people will get surgeries to decrease brain pressure. They'll get drains put in to decrease brain pressure. So those are some things that hyperbaric oxygen therapy can do. But it can also promote new nerve cells and blood vessels. So this is something called neurogenesis or angiogenesis. And this is really the promoting new nerve cells and blood vessels is really where the research is being done for hyperbaric oxygen in chronic brain injury. The top four, with the oxygenation to tissues, the decreasing inflammation, the decreasing cell death, and the decreasing brain pressure, those are in the acute care. Those are going into the emergency room, the ICU. These are all great things, right? We are thinking, okay, these are fantastic things that can help the brain. However, we don't have enough data. There have been standardized clinical studies. Some show that there's a lot of protective effects. Some show that you need to do it early on. Some are showing that they did a study review from 1974 to 2010. That's the second point I have on this slide, that they showed it didn't improve any life quality after a brain injury. So we have all these conflicting things. And then they did some studies in the military service people. And they did show some, you know, they didn't recommend it for post-concussion syndrome. So it really didn't help with the milder head injury. And that was just done in 2012 to 2015. So there's still so much data that's very conflicting. So when you ask your doctor about hyperbaric oxygen, my answer always to my patients is like, I don't know. The answer is I don't know if it's going to help or not, because I have some studies that say yes, and I have some that say no, and then I have some that are in between. But the big thing from these three that I want you to see is in the first one, it says protective effects on brain damage. And then the other one is that the evidence did suggest improvement in survival. So what's going on is there is a potential that hyperbaric oxygen can help in the acute phase, can help in the emergency room, in the ICU. But what are we measuring for outcomes? Are we just measuring if someone's alive? Are we measuring the amount of disability that they have? That's the biggest issue with when we're looking at hyperbaric oxygen studies, is what are they actually measuring? Are they measuring subjective reports, like subjective means what I feel changed, or objective things like what Alicia may do in therapy and have different tests that she runs and see that there's differences in those standardized tests. So those are some of the weaknesses in some of the studies. So that's probably why the data is so all over the place. Not necessarily that it may not help, but we just don't have the data showing robust help because it's potentially all over the place. And then there's age differences too, and the severity of injury. So a lot of the studies out there will talk about side effects. And so a lot of the studies, people will disenroll from the studies because they've sustained a side effect. And so we can't use their data. And so by the end, you might have 50 people that you enrolled, but at the end, only 25 completed the study. So that's not enough what we call power. That's not enough juice to give to the study to be able to say, I have a definitive answer. So, you know, when we talk about some potential side effects, so barotrauma, what is barotrauma? So barotrauma is, if anyone is a scuba diver and they've heard of the bends, when people come up from the depths of scuba diving too quickly, they can get pressure changes. And pressure changes can cause ruptured eardrums, can cause brain bleeds, can cause blood vessel abnormalities, can cause oxygen changes. So barotrauma is a very real thing, because I'll show you a picture in a second. The hyperbaric oxygen chamber, you lay in it and then they close it up and then they pressurize it. They're what we call submerging someone. And it's basically like taking someone who is scuba diving and dropping them to the depths of the ocean in a short time frame. So there's something called oxygen toxicity. Too much oxygen is also a bad thing. So people can get toxic from it. Confinement anxiety, those chambers, when you see the picture, you'll see what I mean by confinement anxiety. It can also cause eye effects. So if we think about it, when you're pressurizing someone, your eyes are what we call vitreous humor, and they're pressure malleable, they're changeable, they're fluid. And so when you're putting a lot of pressure on somebody, that could affect the way their eyes are working as well, because it can cause that pressure. And then seizures are a potential side effect too. So this is what a chamber looks like. It can be very claustrophobic. I laid in one before. They are not easy to lay in. And when we talk about having to lay in them for 20 to 60 sessions, that's a lot. Hyperbaric oxygen is not covered by insurance because they're calling it experimental. And it could be anywhere from $500 to $1,500 per session. There's no standardized cost for it. It depends on where you go. There are a number of centers in Columbus around Franklin County. There are centers down near Cincinnati and up in Cleveland as well that do have hyperbaric oxygen. And they are, charging people depending on their facility, however much. Majority of insurance companies are not covering hyperbaric oxygen unless you use it for chemotherapy or radiation therapy induced necrosis, wound care, and some other skin issues, but they're not covering it yet for brain injury. So, but there is some light at the end of this tunnel. So there is actually some studies going on across the country. So Ohio State is actually involved in a multi-centered trial. Currently, they just announced on February 18th of this year that they're going to be trialing hyperbaric oxygen therapy in the emergency room for severe brain injury patients. It's a national multi-center trial, and they're going to be doing for the acute injury management to study the effects of survival, recovery process, and reducing secondary brain injury. So it is for the acutely injured, not the chronic, but it is a step forward. We're super excited to have this study starting and being able to see if we can affect the lives of our severely brain injured patients. Yeah, so the main things that I've seen for my chronic brain injury patients that have done hyperbaric oxygen They talk more about the cognitive things. So they'll talk about improved alertness, decreased fatigue, improved memory. I have not yet seen functional changes. So improvement in walking or improvement in using upper arm or lower leg function. And I've never had a patient use it for spasticity. Majority of the things that we've seen with chronic brain injury is more from the cognitive realm, at least from my experience, what I've seen. The data that's out there and the research I showed with how it's so varying, that kind of those studies from 1974 to 2010, they looked at physical function, and that's why they didn't have a lot of information, but they did look at cognitive as well. And from the cognitive standpoint, they had more robust information and improvement than they did from physical. Yep, and so that's one thing that they actually have reported in the literature, and that's why this study is started at Ohio State, is that they are looking at these treatments, the hyperbaric oxygen, those first four things that I said it does with the inflammation, the pressures and all of that, that is definitely in the acute care, from the emergency room, in the critical care, and the ICU. So they're looking at trying to do those hyperbaric oxygen more emergently rather than down the line chronically. But there are studies that are going to be coming out or that have been started to be proposed for chronic brain injury to see if it would help. Right now, the information we have, it is time dependent, and it's best to do it as soon as possible. And that's as soon as possible, meaning in the hospital. So right now, when they talk about 20 to 60 sessions, they're talking about daily, so 5 times a week daily sessions. And those sessions are usually submerged for 20 to 30 minutes. This is the area of research that's not there. So when we talk about 20 to 60, sessions, it's because that's what's reported in the literature, but there's no standard of care for brain injury. So for example, like for our patients that have radiation necrosis from their radiation therapy for any brain tumors or anything like that, they could go only up to 30 to 60 sessions because we have a standardized. We know we have to do at least 30, but they could go to 60. With brain injury, we don't have a standard. But we definitely know that when we look across hyperbaric oxygen therapy for all the other diseases that we use it for, a minimum is 20 sessions. So that's why they say 20 and up to 60, because beyond 60, they start thinking about, oxygen toxicity and those types of things. So that's why the range is so broad, but there's no actual standard yet for brain injury. So yeah, when I went through the side effects, seizures that are uncontrolled are one of the biggest contraindications. And then because of the confinement anxiety with what that chamber looks like, so another contraindication would be our really agitated patients, people with severe behavioral changes would not be candidates because they have to be able to communicate if anything's going on. And the only way they communicate is through a microphone. And if they're getting very anxious or if they have a communication disorder that they can't communicate because of cognitive, because you can still do communication, like they'll say, raise your hand or, move a finger if you need something. So you can still non-verbally communicate. So aphasia is not a contraindication, but if they're behavioral and have a cognitive issue that they cannot communicate to us what's happening to them, then that is a contraindication. It's a very good question because people will talk about those craniectomies, craniotomies, when they've had different types of surgeries to their brain and how that affects the pressures in the brain. One of the big questions is well, can I fly again? Because flying also changes pressures. Hyperbaric oxygen actually pressurizes more than when you get into a plane. So you'll feel a lot more effective pressure. Now, when you're in a soft-sided chamber, those home units do not pressurize as much as the ones that are in these clinics. So those big tubes pressurize people a lot more and have a lot more effectiveness, whereas the home soft-sided units don't pressurize as much. And they're really giving you more of the high flow oxygen, and you're not feeling as much of the deep submergence pressure. So in that respect, the soft-sided home ones are not as effective as these big chambers. But they still do something. So it is okay to use the soft-sided chamber if you can easily get out of it, if you can feel that you're having changes in pressures, or if you start having any side effects at all, like any headaches or any trouble with your vision or any of that. And usually what I recommend to people, because the home units, they're also dependent on electrical plugs and all of that stuff. They can go bad quickly. They can not pressurize. They sometimes can lose their pressurization. When you go into those, I would start very short sessions, 5 to 10 minutes at most, and then see how you feel. But the home units are not as pressurizing as the ones in those clinics.
And I would always just kind of say, if you ever have questions too, we're lucky to have Dr. Bavishi here tonight. Just always follow up with your physician. They know your case a little bit better than either of us do. So if you're questioning if these are the best options for you, I would turn to them.
So stem cell therapy. This is another big one that we've been hearing a lot about, and there's a lot of different things going on with stem cell therapy. And what does it do? So the brain doesn't regenerate itself. So we've actually found that out for years and years. Like there's all these things where we talk about plasticity and, diaesthesis, like these fancy terms for the brain, other parts of the brain taking over for parts that are damaged, potentially plasticity, meaning the brain trying to regenerate itself. But we recognize that it doesn't regenerate itself by itself. It needs some of these different cells to help it regenerate. So what can stem cells help with? They can regenerate damaged cells, both in the nerves and the vasculature or the blood vessels, decreases some inflammation, and then it can regulate the bad cells. So there's different kinds of bad cells. One of them is called microglia that can do destruction of the neuronal cells, or the neurons in the nerves. So if we can decrease those cells from proliferating, then we decrease the amount of cells that are getting damaged. But it also depends on the type of stem cells. There are so many different types of stem cells out there. The mesenchymal stem cells, the neural stem cells, the multipotent, the endothelial, and the induced pluripotent. So when we talk about the top three, those are the ones where most of the research is going on, with the mesenchymal, the neural, and the multipotent. But the difference is that the neural stem cells, like it says in its definition or in its name, neuro, it works on neurons, but it can't go on and create any other kind of cell. It can only do a nerve cell. It also can't travel to different places. It needs to be put right where it needs to be. Whereas mesenchymal stem cells, they can change into different types of cells. They can go from that kind of stem cell into a nerve cell, a blood vessel cell, a skin cell. They can change the type. The multipotent are the ones that those are the cells that they can generate the precursors to some of these cells. So, and then the other ones are things that are out there from stem cells, but aren't as robust in the brain world. So it really also depends on the type of stem cells. So when you're looking at stem cell research, you want to look at the types of stem cells because each one has different properties. We still don't know which stem cells are going to be the best for TBI. We know that the stem cells can help. We just don't know which ones are going to be the best. So they're studying, do we manipulate the stem cells? So stem cells that we already have in our own bodies, or do we transplant stem cells? So other stem cells that we pull from other places or other people, or a biobank of stem cells. So that's endogenous versus exogenous. They both have some potential, but we don't know which one's going to be best. There are very small studies that are still showing lots of potential, but they don't have the data to follow people long enough. So longitudinal means we don't have 20 or 25 years of data to see how somebody is doing with those. we have maybe 1 to 2 users. So there are some potential, but we just don't know how big that potential is yet. And then the actual therapy itself, like how do we do it? How do they harvest the stem cells? So they can harvest it from plasma, bone marrow, or fatty tissue. And usually they harvest it 6 to 12 hours before injection. So they would harvest your own. And then they have to prepare them. There's so many different technologies on how to prepare the stem cells. Again, we don't know which technology is going to be the best to give the best determination of that stem cell. And then implanting the stem cells. So they can be surgically implanted. They can be implanted through doing a spinal tap or a lumbar puncture. They can be implanted through an IV infusion, or recently there's some studies about trying to implant them through the nose. Like they actually just kind of go through your nasal cavity and try to implant them that way. So there's lots of different ways to do it. Some are very invasive and some are not. But we don't have protocols. We don't have set protocols. We don't know the set number of treatments. We don't know how many stem cells people need. And unless you're involved in a clinical trial, stem cell therapy is out of pocket. And I didn't put in costs up here because when I researched all the different stem cell places that I found across the country, they varied from $2,000 or $3,000 to up to $10,000 to $15,000 to $20,000, and some of them were $10,000 for just one implantation of a set of stem cells. And we don't even know if that one implantation is going to be enough, or if you need multiple. So right now, I don't think spending the money on something that we don't have a lot of definitive data on is a good thing. But do I feel like clinical trials are a potential and something that, I am hoping that we get more of going for brain injury? Yes. The trouble with stem cells, though, is there's a lot of ethical considerations with stem cells. And as we all saw, trying to get FDA regulation for a vaccine is enough. It took a long time to get that this past year. Getting FDA regulation for stem cells, and especially the types of stem cells, is going to prove to be a very big thing, and especially with the ethics involved in stem cell therapy. So from the stem cell standpoint, do I feel like there's a good potential with them? Yes. Do I know enough to tell you go out and spend $10,000? No. No, there are actually currently no contraindications. The only thing would be is if you did have a brain surgery, and if it was a recent surgery, I would clear it with your neurosurgeon, because you want to make sure that if they're going to do a surgical implant of stem cells, that they're not messing up the surgeon's surgery and potential for infection. Because if they have to surgically implant them, they're opening your brain and surgically implanting them. There is a high risk for bleeding and infection. So you definitely want your neurosurgeon to clear you from that if you've had any type of brain surgery. And then depending on where they're taking the stem cells from, if they're taking your own, they're harvesting your own, then there wouldn't be a risk of rejection or any of that. But if they're pulling stem cells from a pool, you want to really find out where they're getting those stem cells from, what they are, and make sure that you wouldn't have a reaction to them. So ethical concerns with stem cell treatment is it's more along the lines of what are we manipulating? When we start talking about genetics, when we start talking about where are they getting the stem cells from? Are they getting embryonic stem cells? Are they getting them from an aborted fetus or a child? Are they getting them from test tubes? Are they creating them? So, always the question of genetic modification, because these stem cells are cells that are going to try to turn into something else. And so the question is, are we genetically modifying individuals? So there's another ethical question that's always come up. Are we changing, then those are kind of more of the genetics, but then there's also just the the emotional things. What are we changing the will of, God or whoever, the people believe in? And so there are also those questions out there too. The authority that the FDA has is how they are prepared. So like I talked about, there's lots of different technologies and how they prepare the stem cells. And so what the FDA has to do is regulate, when they draw them from your own body, they're then putting them into a device to either spin them down, take out certain cells to try to separate them and stuff. That's where the FDA comes in. So it's on those technologies if you're using your own stem cells. Is that technology, is this lab's technology better than this lab's? Is the technology going to give us the right cells? Is it going to give us the wrong cells? Are they extracting them correctly? So the FDA actually comes into regulating the way the cells are prepared. So they're talking about some of the things that they're talking about with the different types of stem cells, like when we talk about the mesenchymal, the neuronal. So they're talking about how can we help those cells turn into what we want to. Yes, part of it is going to be passive, but the other part of it is how do we keep our bodies healthy enough to allow those cells to do what they need to do. So personally, you would want to abstain from any alcohol, any kinds of recreational drugs, and those are the top two to try to not kill other brain cells. But the other things are nutrition, keeping a healthy diet, making sure you're having your vitamins. And then the last part is once they're a certain time out from the injection for the stem cells, then they also are talking about pairing it with therapies. Because we talk about with therapies, we're trying to do neuro re-education. So we're trying to re-educate different parts of the brain to do or to make up for the areas that are damaged. So part of this is also looking at when is the right time to throw in therapy with this, because we want, once those cells are starting to change into what we want them to, we want to also continue their neuro re-education. So adding therapy into that. And that's part of the research that's going on, is how quickly do we put those therapies in. So platelet-rich plasma, or PRP, is something we use more for regeneration of like cartilage, and we use it in joints. We use it in tendons. We use it more in the peripheral system. Platelet-rich plasma does not turn into neuronal cells, whereas stem cell therapy, you're trying to create brain nerve cells. So that's the difference. But yes, platelet-rich plasma is an orthobiologic that we're using very successfully in joints and tendons, but we are not able to use it in brain because it's not converting into brain cells or neuronal cells. Alicia, and we're very happy to answer any other questions offline if you need, or by all means, there's a lot that's out there in brain injury, and we'll cover some more topics next week.
NeuroNights is financially supported in part by the undergraduate student group Buckeyes Raising Awareness in Neuroscience, mainly through funds raised at our annual Brain Injury Awareness 5K run and 1 mile walk. You can learn more about the event or donate at go.osu.edu/BIA5K.